Good morning, everyone, and welcome. My name is Saili Tarlekar, and I am the Global Marketing Director at Arineta. Today, we have some exciting speakers talking about some exciting topics. Our main topic today is cardiac CT in an office and outpatient setting and how to make it successful. And this is our agenda for today. I am going to invite Scott Schubert to do an introduction for us. But before that, I would like to introduce Scott. Scott Schubert is the CEO of Arineta. He has been an industry leader in developing cardiac CT technology innovations for the past 20 years. Also, for the past 2 years, he has served as chairman of SCCT Advisory Council that led the development of SCCT Starter Kit for new cardiac CT practices. Scott.
Thank you, Saili. Welcome all to the Arineta Cardio Imaging Symposium here at the SCCT. It's always great to be among friends and champions of cardiac CT. Arineta is 100% committed and passionate and dedicated to cardiac CT. Our vision as a company is to promote cardiac CT and the growth of cardiac CT as the frontline test for imaging of cardiovascular disease across the whole care spectrum, from diagnosis, therapy planning, and monitoring of cardiovascular disease, which we all know is the pandemic of our age because it's the #1 cause of death and cost for healthcare systems around the world. And our company is aligned that cardiac CT can be the transformational technology to change this pandemic and this deadly disease. Arineta is the developer of the Cardiograph, the world's first and only dedicated cardiovascular CT system. When I've been in the medical technology design arena, as Saili said, for the last 20 years, I know all the trade-offs when you make a general purpose CT, doing head-to-toe imaging. There are trade-offs that you have to make that sometimes have a negative impact on the performance of cardiovascular CT systems. So when Arineta set out to design and optimize a system specifically for cardiovascular imaging, you can achieve amazing technical specifications and clinical performance when you are designing a purpose-built system for cardiovascular imaging. And the Cardiograph has those best-in-class specifications in temporal resolution, in whole heart coverage with 14 centimeter whole heart coverage and 560 slices, with the highest spatial resolution and many technologies for visualizing stents and visualizing plaque in the coronary arteries and the wall of coronary arteries. Also high BMI imaging with high effective power. And probably the key breakthrough of the Arineta design is what we call stereo CT, and a very novel way to image the heart that also makes the system more affordable and smaller and ideal for the point of care or office setting. The specifications on the system clinically, and you'll hear from 2 of our presenters this morning that have used the system for more than a year, are to provide the highest performance coronary CTA imaging, to provide the challenging patients the capabilities that you need for challenging patients, especially those with high heart rates and unstable heart rates. It is a full vascular and structural heart imaging system, and has also been extended recently to do thoracic imaging as well. So we thank you for your attendance, and I'll hand it over to Dr. Sujith. Actually, Saili is going to introduce Dr. Sujith here, our first presenter.
Dr. Sujit Kalathivithil is the Director of Advanced Imaging for the section of cardiology at Dooley Health and Care. Dooley is based in Chicago area and is the largest independent multi-specialty physician-directed medical group in the Midwest with more than 900 primary care and specialty care physicians. He also serves as Director of Cardiac Imaging at Advocate Good Samaritan Hospital and Northwestern Medicine Central DuPage Hospital. And he will be talking to us about clinical applications of office-based cardiac CT. I invite you to the stage.
Thank you, Siley. Good morning, everyone. So I'll be speaking today about clinical applications of office-based cardiac CT. So as Siley mentioned, I'm with Dooley Health and Care. We are a private physician-owned multi-specialty practice of about approximately 1,000 physicians, 50 cardiologists. We offer a range of services across primary and specialty care, and we serve over 2/3 of the Chicagoland suburbs. And our core philosophy is based on providing high-quality care that's outpatient-based and cost-effective for maximum value. And that's driven by the fact that we have a very sizable Medicare Advantage population. So chest pain has always been an issue for us. Our triage nurses would reflexively send all of our patients with chest pain to local emergency rooms, where they were typically admitted for inpatient evaluation. And many of these patients really didn't need to be admitted. And again, this was really kind of a blind spot for us. So we created what's called a CEC, or Cardiac Evaluation Center, for patients with non-life-threatening cardiac symptoms, including chest pain. And the goal of the CEC is to provide rapid evaluation and on-site testing. And by providing expedited outpatient evaluation, we could reduce healthcare costs and provide greater patient satisfaction. So everyone here is very familiar with the 2021 AHA-ACC chest pain guidelines. So as we all know, coronary CTA is the only test with a Class 1 recommendation and Level 8 evidence for the diagnosis and management of stable chest pain in patients without prior obstructive CAD. So when these guidelines came out, it made it very clear to us that acquiring our own CT scanner was vital for the growth of our practice. So we purchased a cardiograph scanner and we opened our CEC in January of 2022. So we chose the cardiograph for a variety of reasons. First, it has a smaller form factor that's very space efficient, so really nice for an ambulatory setting. The smaller field of view reduces radiation dose and limits visualization of non-cardiac anatomy. As Scott said, this is a dedicated cardiac CT scanner. It's very cost efficient compared to larger detector scanners, yet still provides excellent image quality. So this is our triage algorithm that our nurses use at our CEC when a patient calls or is scheduling to be seen for chest pain. So first we screen them to see if they have severe or unstable chest pain. We define severe as 8 or greater out of 10 in severity. It's crushing in nature, or there's a sense of impending doom, or if it lasts longer than 20 minutes. If they say yes to any of that, they call 911. If they have a prior history of obstructive CADs, or if they, including MI, stents, or bypass surgery, if they had the same symptoms they had when they presented earlier, then again, they should call 911. And last, we do screen them for COVID, so we look for fevers and cough or COVID positivity the last 10 days. And again, if they say yes, they go to the emergency room. If they make it through those 3 layers of questions, then they come to our CEC for evaluation. Our CEC is open from Monday through Friday, 8 a.m. to 5 p.m. So we do schedule about 12 outpatient cardiac CTs every day, and this is a combination of coronaries, pulmonary veins, appendage studies, valve studies, as well as thoracic aortas. But we also reserve an additional 5 slots for daily walk-in coronary CTAs. And on a typical day, we do 2 to 3 walk-in coronaries on top of the 12 scheduled ones that we have. We see anywhere from 14 to 22 patients per day at the CEC. We've seen about 7,000 patients since opening, and we've performed nearly 3,000 cardiac CTs since opening, of which approximately 2,000 were coronary CTAs. We have received the HeartFlow CT Quality Award every quarter since opening, and we've got it 6 quarters consecutively, and we have the highest FFR approval rate in our geography. So let's go over some cases of patients we saw at our CEC. So our very first one is a 60-year-old male with well-controlled hypertension, hyperlipidemia, who exercises regularly. His mother did die of an MI at the age of 61, so he went on a family trip and walked a 3-mile hike with incline. After walking uphill for a mile, he experienced dyspnea associated with chest tightness. He rested for about 15 minutes and his symptoms resolved. He then completed the remainder of his hike, which was downhill, without any incident, and his symptoms did not return. He contacted his PCP the next day and he was referred to our CEC. When he arrived, his EKG showed sinus bradycardia at 53 beats per minute. Labs, including a troponin level, were normal, so a coronary CTA was performed 30 minutes after arrival. And here's what we saw. We saw that he had obstructive coronary artery disease, a mixed plaque involving the proximal LAD. So we are part of the HeartFlow Direct program, so every coronary CTA performed at our CEC automatically gets FFR CT analysis, and FFR CT confirmed the presence of a hemodynamically significant lesion in the proximal LAD, also affecting flow in the second diagonal branch. So the patient was started on aspirin nitrates. We did not start him on a beta blocker because his heart rate was already in the 50s. The entire time he spent at our CEC was 1 hour and 45 minutes. He was scheduled for an outpatient cardiac cath 2 days later, which showed a 90% proximal LAD lesion. Elective PCI was performed, and he had a drug-eluting stent placed to his proximal LAD, and he was discharged the same day. So our second case is a 27-year-old male without any obvious cardiovascular risk factors, normal cholesterol, no diabetes, non-smoker, but 1 month prior to presentation, he caught COVID-19, was unvaccinated, and had moderate symptoms, fevers and cough, for about 3 days. So after recovery, he noticed intermittent chest discomfort that radiated to his left arm. He described it as a substernal tightness, and he only felt symptoms with exertion when he would walk up a flight of stairs specifically. Didn't really notice any symptoms at rest. So he relayed these symptoms to his primary care physician, who ordered an exercise stress echo. Again, not the test I would have ordered, but that's how things played out. So the stress echo was performed. This is what it showed. So his resting EKG was normal, but he developed 2.5 millimeters of flat ST7 depression at 8 minutes into exercise and resolved 5 minutes into recovery. His baseline echo showed normal left ventricular systolic function, and wall motion, his EF was estimated at 60%. His stress echo basically showed multiple regional wall motion abnormalities in the proximal LAD distribution. He did develop 6 out of 10 chest pain with stress that completely resolved in recovery. So given these findings, the patient's PCP was contacted by the reading cardiologist. Now, because his EKG changes and symptoms had completely resolved, he was actually sent to our CEC for same-day evaluation. I just want to make clear, if his EKG changes persisted or if his pain persisted, we would have called EMS and taken him to the emergency room. We felt he had stabilized and he was sent to our CEC. He remained pain-free in arrival at our CEC, bless you. EKG looked normal, and labs, including troponin level, were normal. So a coronary CTA was performed an hour after arrival. And what we found actually on his coronary CTA was a dissection involving the proximal LAD. There was no evidence of any atherosclerosis or calcification. And there are reports in the literature of patients having coronary dissections after COVID infections. Again, we did perform FFR CT on this patient. It confirmed a hemodynamically significant lesion in the proximal LAD corresponding to the dissection flap. So he was actually directly admitted to the hospital for further evaluation. We bypassed the emergency room because, again, he was clinically stable when he presented to our CEC. And the total time he spent at the CEC was 2 hours. So in the hospital, he was started antiplatelet therapy and beta blockade and observed for 2 days. He was seen by our cardiac surgeons who agreed with conservative management since he appeared to be clinically stable, and he was discharged home with instructions to avoid heavy exertion for 30 days. We did repeat a coronary CT a month later, which showed healing with dissection, and he was referred for phase 2 cardiac rehab. So our third case is a 59-year-old male with a history of elevated coronary calcium score. It was 800 back in 2020, who has noted intermittent substernal chest pain for the last 2 months. The primary trigger for this pain is emotional stress. He has severe arthritis of his right knee and has been less active and cannot exercise on a treadmill. And a resting EKG was done, which showed a new right bundle branch block. The patient had a Lectascan nuclear spec stress test ordered by his PCP, which showed no ischemia. Ejection fraction was normal at 57%. But despite this, his symptoms continued to increase steadily in frequency over the next month, and he was sent to our CEC for evaluation. So upon arrival at our CEC, his labs, including a troponin level, were checked, and they were normal. Given his new right bundle branch block and the recent normal stress test, the D-dimer was also checked, and this was normal. And a coronary CTA was then performed 45 minutes after arrival. So what we found here was moderate diffuse disease in the proximal mid-LAD. And if you hallucinate with me here for a moment, if you look at the very distal apical LAD, you can see what looks like a severe lesion over there. There was non-obstructive disease in the circ and RCA. FFR CT was performed, which again confirmed that there was a significant lesion at the very, very tip of the LAD as it wraps around the apex. So these findings were discussed with the patient. Aggressive medical therapy was recommended given the very distal ischemia. He was started on beta blockers and nitrates and discharged outpatient follow-up. He was seen by one of our APPs in the office a week later with some improvement of his symptoms. So his total time at our CEC was 90 minutes. So our fourth case is a 67-year-old male with morbid obesity, BMI of 54, diabetes, hypertension, hyperlipidemia, who was reported intermittent chest pressure for the past year. It occurs at random, sometimes with exertion, sometimes without exertion. He also notes chronic distant exertion that he attributed to his own obesity and inactivity. And back in 2017, he had a Lexiscan SPEC stress test done, which reported anterior wall ischemia, and he actually had a cath done at that time, which showed mild diffuse non-obstructive coronary disease. So he was referred to our CEC for evaluation. Upon arrival, he was noted to have a blood pressure of 130/80, and crucially, he had a heart rate of 88. Lab showed negative troponin. EKG showed low voltages with nonspecific T-wave abnormalities. So at our CEC, our protocol when we have a large patient, which we define as a BMI above 35, we reduce the rotation period on the scanner from 0.24 to 0.27 seconds and use 120 kVs. We generally try to avoid 140 kVs. We find that it makes the contrast dark, but we typically use 120. And to compensate for this loss of temporal resolution by slowing the rotation speed down, we try to get the heart rate a little bit slower. So we definitely want the heart rate less than 65, and we actually try to shoot closer to 60. So in this case, he was actually discharged after 50 minutes at our CEC, and he was returned the next day after getting pre-medicated for rate control. So he received metoprolol tartrate 100 milligrams the night before in the morning of his scan. So when he presented the next day, his heart rate was 74 beats per minute. He was given an additional 100 milligrams of metoprolol as well as 15 milligrams of oral ivabradine, and 2 hours later his heart rate was 60 beats per minute. So we performed a coronary CTA. Now there's a lot to unpack here on this coronary CTA. So his left main showed mild distal disease. In his LAD, he had possibly significant disease in the distal LAD and second diag, and there was mild disease in the proximal and mid-LAD. In the circ, there was possibly significant disease in the proximal circ as well as OM1. And the RCA, there was possibly significant disease in the mid-RCA, and some mild disease in the proximal and distal right. Again, this was a nice example where FFRCT was very helping us navigate all these findings. So FFRCT, and again, which was approved, in a patient with a BMI of 54, confirmed hemodynamically significant lesions in the mid-RCA, ostial second diag, distal LAD, and distal OM2. So he subsequently underwent a cath, which confirmed an 80% mid-RCA lesion, 90% ostial second diag lesion, 80% distal LAD, and a distal OM2. So he had a drug-eluting stent placed to his mid-RCA. He had plain old balloon angioplasty of the second diagonal branch, and the distal LAD and distal OM2 lesions were treated medically. Our final case is a 74-year-old female who was presenting with chest pain. She has a history of RA, hypertension, and hyperlipidemia, had a calcium score of 900 back in 2005, and has been on aggressive GDMT since that time. So one can only imagine what her score was now, nearly 20 years later. She also has a long-standing history of GERD, which manifests as heartburn after eating. Over the past couple months has noted heartburn without eating and sometimes with exertion. So she was referred to our CEC for further evaluation, of course, arrived on a Friday afternoon, and she arrived with her daughter, who was a physician, who was very concerned. So her EKG was normal, troponin was normal, and her heart rate was 58 on arrival, so a coronary CTA was performed about 30 minutes after arrival. So what we found in the coronary CTA, it showed heavy calcification of the distal left main extending into the ostial LAD and circ, and we could also see a lot of calcification in the proximal LAD as well. And given the degree of calcification, we really had a hard time seeing the lumen and quantifying the severity of stenosis. We did see what appeared to be non-obstructive disease in the mid-LAD, mid-circ, proximal, and mid-RCA. But again, FFRCT, when you have high-quality images, again, can read through the calcium in this case and confirm the presence of a severe stenosis, very severe, as you can see by the FFR values involving the distal left main. And it confirmed that the RCA disease was not hemodynamically significant. So the findings were discussed with the patient. She was directly admitted to the hospital. Again, she was pain-free, at the time, and her troponin was negative. Cardiac cath was done on Saturday morning, which confirmed a severe distal left main stenosis with targets in the LAD, diag, and OM1. And she was seen by our surgeons and underwent bypass surgery on Monday with a Lehman LAD, vein graft to OM1, and vein graft to diag. And again, that whole visit, where we made the determination she had left main disease, took 90 minutes. So, in summary, our CEC allows us to offer expedited outpatient evaluation of heart disease. And chest pain has been a major focus of our CEC. CCTA is our preferred first-line test in patients without prior obstructive coronary disease, in line with the 2021 ACC/AHA chest pain guidelines. Our cardiograph scanner is the cornerstone of our CEC. We actually have plans to open up 2 more CECs with cardiographs in each one. So, thank you for your attention.
Thank you, Dr. Sujit. Those were some interesting cases there. Okay, so next we have Kyle Brownell and Jennifer SP from Capital Cardiology Associates speaking to us about cardiac CT in an office and outpatient setting and how to make it successful. Kyle Brownell is the Assistant Director of Operations at Capital Cardiology Associates and oversees all of diagnostic imaging. Her career began as a nuclear medicine technologist, which she still is clinically active in and has over 27 years of experience in medical imaging that includes comprehensive overview of imaging departments, implementing new imaging technology, coordinating staff, and establishing best practices. She is also a member of Hudson Valley Community College Medical Imaging Advisory Board. And Jennifer SP is a CT technologist for the past 20 years, 9 of which she spent as a CT manager and technical director at Capital Cardiology Associates, a private cardiology practice in Albany, New York. Jen also serves on the SCCT's Technologist and Nurse Committee.
Good morning. Thank you for the opportunity for us to share our experience in performing cardiac CT in an outpatient office setting. I'm Kyle Brownell, as stated. Capital Cardiology is a private cardiology practice based in Albany, New York. Began in 1990, where 12 physicians came together from 2 offices to form Capital Cardiology Associates. Today, we are now over 30 cardiologists with 20 advanced practitioners at 4 locations. Diagnostic imaging has been a vital part of our growth over this time. Our first CT was installed in 2005, which was a VCT. The VCT was then replaced in 2019 with a cardiograph. Our second cardiograph was then installed this past March. Over time, you can see that we've also added cardiac PET CT, we also have echo and TEE, and we have what's called the ECA, which is an enhanced cardiac access, very similar to what we just heard. Our vision is no barriers to the community seeking cardiac care. That's provided by Dr. Gus Delago, our CEO. Our physicians would see patients in the hospital, but they couldn't get same-day testing. They couldn't get next-day testing. They couldn't get the following day testing. So that's what began us growing our diagnostic department. The ECA is a large portion of that now. It's a walk-in clinic, Monday through Friday, 8 to 4, where patients can be seen, whether they're sent by a primary care physician, sent for orthopedic cardiac clearance, or they may be sent even by the ER physicians once they've ruled out they're not having a heart attack at that time. Our workflow is standardized with on-site testing, on-site lab, as well as all the diagnostics. This is just a quick visualization of how our ECA has grown in volumes over time and when we added our second one in 2021. With that comes our diagnostic volumes. One of the questions that we're asked often is if you add cardiac CT to your diagnostics, does that cannibalize your nuclear program? No, in our experience it does not. It enhances it, it adds to your wheelhouse in that regard. The red outlines echo. For me, E, echo, everyone gets echo. Blue is CT, as you see, it's continuously grown over time. And the yellow is nuclear, and the green is cardiac PET CT. When you're adding the nuclear and the PET together, they have been outperforming slightly over CT in years. But in the most recent years, and what I anticipate this year, is CT is going to perform more exams than nuclear PET combined. With the cardiograph, what we found was when we replaced the VCT back in 2019, on the bottom image is our Southwoods location. The space is large in that it's 15 feet by about 24 feet, but the cardiograph it's only about 10 feet by 6 feet. So if you're going to replace a current CT unit, it fits in there nicely. And you have a lot of additional space for your storage and your workflow. The top image is the location where we just installed in March. That's a much smaller space. That space is only about 14 feet by 20. Once again, fits nicely into that space. Even if you're looking to replace your nuclear and put in CT, the cardiograph fits in that space nicely because it is so small and compact. From a workflow standpoint and staffing model, one of the questions we're asked quite often is, can you do it with one CT technologist? Could you? Possibly. We recommend two technologists. Two technologists where you can have them trained to become competent, confident, and then become efficient. Learning cardiac CT is a specialty, and you want the staff to be able to be confident in what they're performing. You also want to keep that scanner moving and the patients moving. So having two technologists to be able to do that, we've been able to have efficiencies where we can do up to 22 exams with two technologists. 3, we can do up to 40 on non-structural heart days. On structural heart days, as you can see, the volume goes down slightly, and we use three CT technologists. Overall, we have 2 CT units, cardiographs, and 7 full-time technologists to support that workflow.
Thank you, Kyle. From a technologist perspective, we want to talk about how we achieve volumes with quality first. The first thing is you want to have a knowledgeable cardiac CT tech. Technologists tend to be pushed into scanning with a shortage of the technologists and institutions getting busier. It's harder to find technologists that have any cardiac background at all. It's important for them to be trained not only on the scanner, but anatomy as well. Also, you need to have, if possible, good standing protocols. That way you can maximize the amount of scans you can produce. It allows for your cardiologist to continue to see patients and the technologist and nurse to collaborate on getting high quality, low dose scans. Communication between all of your staff is key. Communicating and making sure that we're all on the same page makes a huge difference in the workflow and efficiency. We also want to have a no problem attitude. At CCA, it is not no. We never say no. It is no problem. Technologists, nurses, ancillary staff need to be willing and able to think outside of the box. How can we get this done, and what do we need to do to get it done? Also, from my perspective as a CT technologist, cardiograph has made a huge impact in cardiovascular scans. Here are some examples of how it's improved our workflow. We've been able to decrease the number of patients that were canceled due to claustrophobia, high heart rate, increased heart rate after full protocols of medications given. Lots of times on the 64 slice, patients would get anxious and become extremely nervous, and their heart rate would go up, which would then put them out of reach being able to be scanned based upon our standing protocols. Our radiation dose has improved for all of our scans, including TAVR, which we scan as a full gated coronary. There is no step artifact in your LAD or your aortic valve for TAVR, which allows us for less repeats. In fact, we actually have not had any repeats with regards to any type of artifact through the valves or the coronaries. We have ease of use for the CT technologist. Technologists can scan the same day as applications comes. So in the morning, you set up your application, you work with applications and set up your protocols, and then you can start scanning patients same day. Can have an increased amount of patients that can be scanned without any medication. We used to do calcium scores where we would medicate patients, so now we can scan patients as late as 4:45 and still be out by 5 o'clock. We do still medicate all of our patients, but we can actually get higher heart rates, which you'll see in a few scans. And doctors like the scans we don't get phone calls anymore or tasks, and they compliment us on how great we're doing. So that's a great positive for us as technologists. So here are some clinical examples that you're going to see. Something I'm always asked is I'm going to show you some images that produce myself and my team of 7 technologists. These images are to show you what comes up questioning regularly. Can you truly get a TAVR on this scanner from carotids to femorals? How about a high heart rate? And what are the limitations? And do you have to beta block? So the first scan is going to be a high heart rate 89 to 99 beats per minute, so we have some variability there as well. The BMI of the patient was 27.5, and we scanned phases 40 to 80. Ended up being about 2.5 millisieverts. So you can see on this scan, very clear RCA, nice images. The next one is a high BMI of 60.9 for PE using the 450 millimeter coverage. You can see, although we have some different resolution outside of the 250, this is an excellent scan on a patient with a BMI of 60.9. Next one is high calcium. We had a calcium score of 935 on this patient for a coronary, which is close to our cutoff. For our cutoff, we stopped scanning at 1,000, and the patient goes back and sees the doctor. So you can see there's no blooming artifacts, and you can also see that it can see disease. We also don't utilize any type of FFR, so we can't see through as other institutions can see. 8 stents. This patient ended up having 8 stents. This was a scan, full gated chest that we reconstructed down into the 250, 140 millimeter coverage. We typically only scan 1 stent for coronaries for our protocols, but as you can see, no blooming artifact. Excellent scan. And pre-TAVR planning, that's the biggest one that everybody wants to know. Can we really get great images from all the way from top to bottom, essentially? So as you can see, you can, the patient had a BMI of 45.6, and we were able to scan from carotids all the way down to femorals. Next is field of view. The advantages of having the 250 field of view is it's coned down and higher resolution of the heart. Your disadvantages is that you may not get an entire lung field. Larger hearts can be more difficult to obtain isocentric positioning. The next is the 450 field of view. The advantages is to be able to obtain full lung field, allows for segmentals for PEs, and pleural fusions. We also utilized it during COVID. Patients would come into the clinic, and not be sure, and we'd want to take a look at the lung field. As well as the disadvantages of that is outside of the 250 field of view, there is a noticeable but small change in the resolution. However, they still have excellent image quality. In summary, when you want to optimize a cardiac CT program, the cardiograph fits in a smaller space than traditional CT. You have a steady increase in cardiac CT usage without cannibalizing your nuke or PET units. You can lower your radiation exposure. Your field of 450 field of view, you can see your lungs. 450, 250, the field of view 250, higher resolution of the heart. And you can start, if you start with 2 skilled technologists, you can really ramp up your program. Superior imaging quality for a cardiac CT. Thank you.
Thank you, Kyle and Jen. So our final speaker for the day is Ginger B.S. Brock, and she will be talking to us about cardiac CT economics, breaking down the myths. Combining over 25 years of clinical and operational experience with the most recent scholarship in delivery science, Ginger serves as Executive Vice President of Care Transformation at MedAxiom. Patient centricity, team-based care, efficient resource utilization, fiscal responsibility, and servant leadership are signatures of her work, with organizations large and small across the United States. Prior to MedAxiom, Ginger served as Chief Operating Officer of the Cardiovascular Group at Centra Health in Lynchburg, followed by directing operations at West Michigan Heart in Grand Rapids. Ginger, I welcome you to the stage.
Good morning, it's great to be here. I appreciate the opportunity. And I'll start by saying, if you have questions about CT, technical pieces, that is not me. But what you did hear is what I am in the organization that I come from at Axiom is we live in that delivery science, delivery implementation space. So when we see new technologies, updated guidelines, ineffective way we currently deliver cardiovascular care, that's the space that we live in and the area that we believe we're experts in. So shifting that paradigm to be early adopters, appropriate adopters for cardiovascular care for our patients. So what I want to walk you through today is we had the fabulous opportunity of working with Arineta and GE related to understanding where CTA fits within our, I'm going to say our economic model, but more importantly, our clinical model and how that clinical model ultimately affected our economics. Because when it comes to CT, if there's an elephant in the room, and I realize that at a conference like this, you are all high users and early adopters and long-standing adopters of CT, but when it comes to implementing programs like we just heard about, it's typically the economics that get in the way. Between access to technology and investing in our facilities, in our spaces, in our cameras, access to our readers and shifting the way we utilize our cardiologists and their skill sets and CT versus SPECT and echo imaging. And then just how do we operationalize these things in the most economic way? So what we did was we took some time and did a full analysis of the research that had been put forth related to CTA and really focused on what happens when you implement or add CTA to your care delivery models at the different use cases and what happened for downstream. So not only what happened related to the actual scan itself and the test itself, but what did that mean for clinical care? How did it affect what happens after that scan and what happens within our larger patient populations? And then we looked at, so as MedAxiom, as an organization, we actually represent, believe close to 10,000 cardiologists in the country and their delivery organizations. We collect annual data on our practices, and we were able to look at, I'm going to share some of that with you this morning, look at that impact. So for those that were high utilizers of CT, do we see an impact in their other modalities, and what did that look like? We saw a little bit of that already this morning, which again, I think is important. And then we took all of that findings, so there's a publication that would be available for all of you for reference in a dossier, but we took all of that and used it to inform the calculator that helps a program when you're either looking to expand your role of CT or introduce, help you better understand what that might look like from a patient volume as well as a potential economic perspective. So what I want to do in the next 6 or 7 minutes or so is kind of walk you through, I believe there's 4 or 5 myths here. And again, I realize that I'm preaching to the choir this morning, but my goal is that there may be some really good information here you can take back to your programs as you look to advocate for expanding your own program. So number 1, CTA has limited use, and we know the reality of that is it's exponentially increasing around the different use cases between all the research that's come out, the guidelines that are come out. And so what we're really seeing is that cardiac CT has multiple use cases within the way we deliver care or how we deliver care within cardiology. We're seeing it increasing incrementally in the US with our guidelines that support coronary artery disease detection, diagnosis, and pre-planning management. But in addition, and we heard examples of this already this morning, CT use is expanding for vascular, structural heart, and electrophysiologic procedures or indications, pre-procedure planning. So what we did with our publication is we basically put together a framework that really walks you through the care delivery model for our heart patients. So between prevention and wellness, diagnosis, therapy planning and treatment, and monitoring short and long-term outcomes, we went through and summarized the objectives of care in each of those areas and where CT plays a role. The reason that this is an important framework is because when you start to look at where are the patients within the organization and the population that we're managing that deserve CT, this allows you to go back into your way you care for those patients and your historic data to say, all right, where are SPECT has a higher reimbursement than CT, so how do we make that shift if there really is a shift? So let me tell you what we found. So this is our MedAxiom data, and what we did in 2021 is we took all of our CT users that we had in our database. It equated to about 140 or so programs. We took the top quartile of users, which ended up being about 17 programs, and the quartile was based on their actual uses. And we compared really what happened in those programs. We aggregated the data up to the quartile level, and without going through all of those numbers, this is basically the summary of that. And this graph is in that publication, so if you want to see the data a little bit closer. But this is what we learned. There was virtually no change to SPECT volumes between those two cohorts, between the top quartile and the rest. There was a slight decrease in SPECT to new patient ratio, so it was the other measurement where we looked at the number of new patients and the number of SPECTs. There was a slight decrease in that between the two cohorts. We actually saw an increase in use of stress echo in the higher CTA users. So again, I would, not sure why, but I believe probably because they became much more deliberate around those chest pain workup and chest pain type and urgent sort of programs of which those patients typically represent. We saw an increase in cath volumes in our higher uses of CTA, but probably more importantly, we saw an increase in PCI to cath. So for those caths that they were doing, there were less diagnostic only and more that were associated with percutaneous intervention. So again, what does that mean? Well, we believe it means that those that are using CTA have the ability to be smarter about the patients that they're referring on to cath, more likely to have disease that needed to be intervened upon and less potentially unnecessary diagnostic caths. All right, myth number 3, CTA value is challenging to quantify. And I think that's one of the biggest things we wanted to do with this analysis was create a construct in which you could apply your own programs, volumes, and patient populations and use cases and really begin to objectively quantify what sort of impact are you going to have. So this is where we went through a lot of the literature, pulled out those benefits, pulled out the actual financial numbers or percentage adjustments, and then applied it to the 2023 data. So what we then put together was a use case summary around what my program might expect. So you can kind of look the different use cases over on the left, and then some, again, considerations followed by potential revenue opportunities. Again, the idea being, are we creating an environment where we're actually setting ourselves up for an economic loss for our program, or by doing the appropriate care, what would we begin to expect? And really what we found was very positive. So whether it's calcium scoring or CCTA for CID, there is an uptick by adding CTA to your modalities and to your imaging program. And then for the non-CAD vascular, significant uptick, as well as for structural heart. And the reason being is those are typically incremental growth areas. Those are areas where maybe you've been doing some CT on those patients now, but you're sending them out to another location. By having your access to your own camera, you have the ability to bring all of those studies back in-house. As those programs, I haven't been in a structural heart program yet that hasn't continued to grow since they started. As those programs grow, that's growth to your CT imaging program. So significant revenue opportunities, again, when you own your own camera and have the ability to operationalize your own camera. So just want to leave you with a few takeaways. So the first one, and you all live this every day, CTA use is expanding. Number 2, CTA use is not an exchange of strategy, and we've proven that with our data. Number 3, programs with and I think this is the most important one, programs with the best clinical and economic outcomes develop an organization-wide plan. They don't dabble in CT. They adopt it as part of their delivery model, and you heard 2 great experiences and examples of that already this morning. This is the patient population, this is what they observe or deserve, And this is the care pathway and the operational infrastructure that we put into place to meet those needs. And what you saw is those volumes go up over time. The patients are there. The guidelines support that level of care, but we need to put the infrastructure in place in order for that to happen. That then leads to effective clinical adoption and appropriate care for our patients. And then finally, overall economic impact is positive when implemented widely and effectively. So full time, full portion, or full access to your technology integrated as part of your care delivery model.
I'd like to thank all our speakers and all the attendees for joining us here at the Arineta CT Symposium. Given the time constraints, I'll ask our speakers to be available up front here, but we won't have a formal Q&A session. And I would like to invite all of you to visit us at Arineta down in the exhibit area after the scientific sessions. Thank you so much for your attendance.